nationwide detailed report concerning mental health in Uganda. Let's join, I think, them.
Yes, yeah, let's join them. Of course, the Bethany crew is already there to give us exactly what is happening there. And this is what is happening at Silver Springs, and we will be expecting that the guest of honor will be arriving soon to give us the presentation for the day. And not to forget Dr. Hafsa Lukwata, who will also giving us a detailed report on the mental state within the country, different in regards to the region. So, but let's go back to Silver Springs and see what's happening.
As a human rights advocacy, to HIV/AIDS advocacy in the early 2000s and the late 90s, persons living with HIV had to fight for their space. Africa had to fight to get ARVs. Otherwise, ARVs had been made for almost 10 years. Some other parts of the world were enjoying. That disease now has a chronic medical illness. In Africa, it was still an acute infectious killer disease for nearly 15 years. It took for real advocacy. It took for the president of this country to stamp his feet down and say, we are going to manage, unless you send us the thing, we are going to put our ABCs. And tell the country we are going to abstain, we are going to be faithful. And we are going to use condoms. Champion for advocacy. Who is our champion this time? To tell the whole country, look, mental health is your right. And we are going to do ABC. Oh, how I wish the president would say that. How I wish the minister would say that. That mental health is my right. And we are going to do ABC. But we need advocacy from all corners, from all of you, from service users, service providers, to even well-wishers. We need everybody saying the same thing. At individual level, we may need to get into groups. Groups that continue that work for advocacy. Groups that can attract some sensible funds. Because there is power in togetherness. TASO was able to pull it off. It's an organization for service users, and they attract lots of money. And we can go on and on with examples in the HIV space. But the bottom line is we must be at the forefront of every mental health discussion. We must negotiate and influence and shape policy. And we insist on it too. Short of that, it's just going to remain something that was declared on the 10th of October 2023. We can target people outside ourselves, our connections, our social networks, our social influences. These days we see a lot of social influencers, but they are influencing the wrong thing. They should be influencing the idea of mental health is a universal human right. So it behooves you to educate your family, at your workplace, in your friendship groups, to speak mental health and make sure that they understand. We need to improve mental health literacy. How about at the community level? Our social environment is something that needs change. And we should focus on community norms and values and attitudes, and the whole power structure of our communities. Who can speak in your community that people will listen to? What are some of the beliefs that may be driving mental health issues? These are things that need to be addressed. And I'm very happy that in this gathering, there are lots of people doing community work. And their community mental health work targets mostly these social determinants of mental health. They are addressing social norms and values and attitudes. I think we need more people working at the community mental health level. We need more organizations there. We need more funding sent at the grassroots because it's monumental. It's monumentally important that we address these community norms. Of course, we must promote inclusiveness and compassion. I don't know when some of you who have eaten more Christmases than I have should venture and tell us when Ugandans lost compassion. At some point, we were known to be the most compassionate, the most helping country. When did we lose compassion for one another? It's time for us to recover some of these important values. At the population level, if we come back to the state and to our laws and policies, we must be at the table discussing the policies, the regulations, the procedures that speak to mental health. We must be brought to that table and not get things after they have already been discussed by people that have not yet accepted that mental health is a universal human right. So what can the state do? I have a few ideas on what the state can do. The state should tax, finance universal mental health care. The way we are talking about universal health care, I have not heard mental health being mentioned there yet. We need tax-funded universal mental health care. We need people to go to hospitals, just walk in, and they are covered for mental health care. Right now, you have 3 hospitals, to the best of my knowledge, or 3 insurance companies even, let's say, who provide mental health cover. 3. And it's ridiculously expensive for somebody to get mental health care. And this is going to be for a duration of time. We need the state to help us to be able to access care and should be funded by the state. The discussion about Butabika being there for us all should stop. We should stop. Butabika is a national referral hospital. We need to go to our local clinics and get health care, mental health care, if indeed it is our right. The state must come out clearly and show responsibility in fulfilling this idea of rights to mental health related to our human rights. Somebody needs to come out clearly and show us by example. You could start by decriminalizing suicide. We've been dancing that little dance for way too long. Suicide is often a cry for help, somebody in an exceedingly difficult situation. The state should be able to provide equitable access to mental health knowledge and resources. The duty is on the state. We've done what we can. We've given literacy talks at our local churches. We've gone to schools, we've talked. We've even gone to funerals and somehow squeezed mental health there. At individual level, we have done. The state, please invest in mental health literacy. Because only by doing that shall we break the barriers to mental health care. So, right now, mental health is a universal human right. As a universal human right to me, for this 1 month that we have enjoyed it, it is but a dream. It's just a dream. It's a beautiful dream though. But it's going to remain a dream, an aspiration, a lofty aspiration that will amount to nothing unless actions do take place. Because we need actions in order to address those perennial problems of mental health. If indeed it is a right, a human right, then we must address our perennial problems. We must break down those barriers. Most of them are structural. We must break down these economic barriers, the political barriers, environmental, marginalization, and minority groups must be addressed. The universal human right to health, to mental health, must always be embedded in the right to the protection, the right to agency, the right to freedom, inclusion, and dignity in mental health care. And until this becomes our reality, each one of us starts to feel that they are free enough to talk about their mental health, free enough to walk to any doctor, Dr. Kalani, Dr. Dokonyero, Dr. Who, without having to call me in the night and say, well, but can you come at home? Can I come and see you outside of Mulago? Can we meet in some gardens of a hotel? We have practiced mental health everywhere. Because people do not feel free enough to enjoy mental health care. In part, because you will start to discriminate against them. So as I part, I would like to challenge everybody who is here today. That, well, we can say, and this is a very nice thing to aspire to, mental health is a universal human right. In Uganda, my mental health, my right. But shall we walk the talk? How do we ensure that this is the lived experience of every Ugandan? That's what you should live here with, so that in a year's time when we meet to take stock, some of your presentations will be about how you have observed this universal human right. I thank you for listening to me and for giving me this opportunity to share. Thank you very much.
Thank you, Prof, and good afternoon, everyone. Prof, I think I can call you Kimon because the other name is a bit complicated. Yes, I wish to take this opportunity to welcome our chief guest, the Permanent Secretary, Ministry of Health, Dr. Diana Twine. Please join me, welcome her. Also allow me welcome the Dean School of Public Health, Professor Rhoda Wanyenze. So we can all affirm that my mental health, my right. Can we all go? My mental health, my right. So thank you. Allow me to take this opportunity to welcome Professor Rhoda Wanyenze, who's going to give us the key findings from a study. Professor Rhoda, you're welcome.
Thank you. Thank you very much for the opportunity for us to be here and to participate in commemorating this very important day. And may I start by saying, my mental health, my right. So our chief guest, the Permanent Secretary of the Ministry of Health, Dr. Diana Twine, and our partners present, WHO, the World Bank, and all the others. Our partners in this work, Butabika Hospital, ED, Dr. Naku, and your team, our senior colleagues from Ministry of Health, Ministry of Education, who were part of this work, and colleagues from the School of Public Health, and all of you, colleagues in your respective capacities. A good afternoon. I'm happy to join you today. From my leave, I was trying to hang up the boots. I heard that from the keynote, but I thought this was so important, I needed to be here and be a part of it. Now, I had several things I wanted to say, but I look at this program, and by this time we should be doing a Q&A. So I'm going to cut down what I have to say. But I'll just mention perhaps 2 or 3 things that I think are really important. That yes, mental health is such a critical part of our health. And we've known this for a long time. It features in our should I say, traditional definition of health by the World Health Organization. It has physical, mental, and social well-being. And I think increasingly lately, we are talking about well-being and not just talking about the absence of disease. And I think COVID did wake us up in many ways to begin to think about health in a different way. For us in public health, we are resetting. We had gone off track at some point when we did not emphasize the determinants of health as much. But we all know from the SDG framework that we cannot deliver health and well-being without looking at the critical sectors that contribute to health. So we need to think about all those key issues. At the same time, sometimes we think about health as being in a competition with investments in development. And this must be hard for PS because we are all saying we need to have everyone talk about mental health. But I know she's thinking everyone should talk about malaria and everybody should talk about NCDs. Dr. Mutunji is going to say the same. So it must be very difficult for her to process. But sometimes I think we could just make it easy by looking at health and well-being and health promotion in a combo. There are several things we can do collectively that can actually give us well-being in many ways together, where we can address our mental health, the broader NCD issues, and so many others, if we got it right in terms of health promotion. But I don't have enough time to get lost into that. But Madam PS, health is not in competition with development. And development is a determinant of health. We've known for a very long time. But increasingly we know that health is a determinant of development. And I think we need to turn the tables. Because the people that think health is in competition with development don't know that we cannot develop if we are not healthy. And we've just seen this in COVID. And we don't have to take too much to convince anyone that health is a determinant of development. We must invest in health. We need healthy people that are smart, whose brains are working well, so that they are better educated and they can develop this country. They can give us the innovation so that we can deal with the challenges we have. And we cannot do that if we don't have health and if we don't have good mental health. I really hope that we can redesign that message, Madam PS, so that we can get, especially the PS of Finance and Minister of Finance, to start saying health is a determinant of development and we must invest in health for us to be able to achieve what we want in terms of the economic indicators that we are looking at. And that development is nothing without livelihood. That is also important because for a long time, we also think about development in terms of numbers, but people don't have a livelihood. So it's wellness, it's a livelihood, and that's what is going to give us development. So I thought I should emphasize that. And I could hear the keynote speaker, Dr. Odokonyero, Raymond, excellent presentation. I think you brought out a lot of those issues in relation to mental health. And thank you so much for your passion and for delivering such an eloquent presentation. The last thing I wanted to mention is thinking about the continuum of care and where does it start. I think we need to carefully be thinking, what is it that's happening in our homes? I had the keynote talking about what's happening in schools and what's happening to our children in schools. They don't even have time to breathe and think. And I know Minister of Education is here, and I know that you're doing something about changing the curriculum. But what we are doing now is not going to help our children to be thinkers and problem solvers. They need to have time to breathe. They can't just be reading and sleeping after midnight and waking up in 3-4 hours and then starting the same again. But what's happening to us in the homes as well? What are we doing for the children that are at home? The workplace. What's happening to the workplace? So many people are so stressed in the workplace. They're not happy to go to work. But they have to, because they have to have a livelihood. They need that money. Can we make the workplace more friendly so that people are happier? Is this part of what we define as good leadership? Making people happy so that they are more productive. The spaces where we spend most of our time, what is really happening there? I think there is a lot we probably need to reflect on, all of us. And as we think about my mental health being my right, I think we need to think about the spaces where we have responsibility and control. Can we make those spaces better? Can we make those spaces and someone's life better and happier as we work in those places? So I will perhaps stop at that in the interest of time and say it's really very timely for us that we have this study that's just been conducted by colleagues from the School of Public Health in collaboration with colleagues in Butabika, looking at the extent of integration of mental health services in primary health care, community, and schools in a few selected districts. It's such a timely opportunity for us to be thinking about this. And perhaps this is just a telltale what you're going to hear of what we should be exploring and seeing in other spaces as well. So we really do appreciate the partners that made this possible. Butabika Hospital, thank you so much for working with us. I hope we can work more with you so that we can integrate mental health in public health more than we are doing today. Thank you to the World Bank for funding this study. And thank you, Ministry of Health, for being a good partner in this study, as well as the Minister of Education. My last call is that these findings should not just be sharing figures to color up this World Mental Health Day, that these findings should get all of us thinking about what role we can play to advance the opportunities that exist. They will share some challenges, they will share problems, but I hope you can have your lens on the opportunities that exist, so that when we come back together next year to celebrate and commemorate this day again, we shall be looking at what progress we have made in this. So thank you very much for the opportunity for us to be able to share this, and we have the team here already. We have Professor Fred Makumbi from the School of Public Health, and then we have Ms. Rosa Kisa, as well as ED Butabika, Dr. Juliet Naku, who are going to share with us these findings. And then I'm not too sure we have any opportunity for questions and a reflection. I see a Q&A to be moderated by Dr. Naku, but the time is not too good. So Dr. Naku will see if we have any opportunities. But I believe there will be, even if it's a contact that we can use to gather those views, whether it's email or telephone, that we can hear from you if you're not able to speak today. So welcome, Professor Fred Makumbi, to start us off. Let's receive Professor Makumbi.
Thank you very much. Yeah, so thank you very much, Professor Rhoda Onyenze, and you are very much welcome, the guest of honor, the PS. The Dean has clearly spelled out a lot of background about this study, and we shall focus a lot on what did we find out when we are given this opportunity to conduct this research. Being Makerere University, where we do transformative and innovative teaching, research, service provision, as I said earlier on, we generate evidence. That, again, Dean has echoed that can inform us on what do we need to do. But also, as you shall hear clearly, we tend usually to give barriers, challenges for Christians who read the Bible. There's a book of Lamentations. But at some point when you do that, you also have to remember there's a book of Proverbs where we need to find opportunities that tap into those. So yes, challenges will be there, but how do you manage and overcome them? So when this funding came in, one of the things that we wanted to look at was the extent of integration of mental health services in those areas, primary health care facilities, communities, in this case defined as villages, and as well as the schools. And the focus for the schools, we focused on primary school settings where the tools that are available, as will be expounded on by by Dr. Naku meant for children aged 11 to 17. So those dynamics and details will be provided. And thank you very much, the keynote address which was given. A lot of things could resonate. And I was saying, oh my God, he speaks as if he was a respondent on some of these. But so we are so glad to hear that these are able to sync. And very importantly, as again has been said, we want to get out of the boardroom. We want to get out of this seminar room or data sharing room and see what can we learn and implement out there. There are many implementing partners here. I'm taking all this time because they are still doing the IT, but it's also a benefit because it gives us a big picture of. But as we present, please remember, when we go the funding, the focus was on primary healthcare facilities. That's where we focused our research. Schools, as explained, and villages, defined as communities in this case. And you'll certainly be able to see all these three kind of get interlinked into primary health care and subsequent referrals up to the national level. The team was composed of a great team of individuals from different institutions, the University of Tabika, Ministry of Education, Gender, WHO. Everybody was part of this because it required everybody's contribution. And as indicated, the extent of integration. Integration is a very tricky issue in terms of defining, but we shall see how we operationalize this in this case. Some of the things we looked at were the patterns of common mental health problems in those areas, availability and access and quality of those services, mental health, exploring the opportunities for and the challenges of integrations. Like I said, Book of Lamentation, but the opportunities all the time. We can tap into the forms of community mental health services offered in the villages, in this case, communities, the knowledge, attitudes, and the practices of learners, of individuals out there. But also importantly, we also looked at the alternative forms of care, and we shall see what alternative forms of care, because health is made in home, as clearly stated by Professor Mbaswa many years ago. But where did we go to conduct this study? This is a purely descriptive studies are kind of helping us to get a picture, a big picture of where we're doing the study. So we went to 3 to 4 regions. In those regions where we went, were determined by the burden of mental health problems as defined by the HMIS data of 2022-2023 fiscal year. And in the northern part of the country, we went to Ajumani, then we went to west in Bushenyi, and then we went to Kapchora, and central, it was Butambala. So those ones in red are the districts with the highest burdens as defined by HMIs at the time. So we selected at least one district from each of those regions. And kind of giving a background to this, we have a big picture. I would like you to focus on the fourth column, which shows DHIS2 rates of mental health conditions. Certainly highest in Kapchora 305, and next by Bushenyi 206. As I've seen. But we try to extract some data from HMIs for the given period to get a sense of the number of cases reported in the facilities in those districts. Some selected number of cases alcohol-related, alcohol use, substance drug use, anxiety, unipolar and bipolar. What was interesting, certainly, alcohol use had the highest number of cases. But again, when you look in terms of districts, appears Bushenyi reported the number of cases documented as per the data that we extracted at the time. So when we did this survey, again, snapshot, a picture of what's going on beyond the HMIS data, we went to those 4 districts to get a sense of what's happening out there. So overall, without much ado, we had a response rate. When we interview, when you go out to look for 100 people, how many do you see? It's very, very important. So on average, we saw more than 95 out of 100. So which means it was a very nice, well-conducted study in terms of tracking those that we wanted. But also, you can get the numbers, but the stories behind numbers can be obtained from focus group discussions, which we did, key format interviews, as well as in-depth interviews conducted with the various individuals that we are selected when we did a qualitative study. What did we find out? I will present the community component. My colleagues present on the schooling learners, as then the other will present on what we found out in the primary health care facilities that we visited. In the community, villages, as we may want to define them in this case, majority were rural of the respondents in the villages where we interviewed. Many of them were females. Again, many of these districts kind of were rural, so we are not so surprised to see this. These were very consistent, and they are peasant in terms of occupation. These demographics are very important because we're able to understand what their results mean. At some point, I will call Dr. Naku to help me expound on this. My area is in statistics, public health, epidemiology, but I love public health, where mental health is part of the things we are doing. When we assessed the patterns of common mental health disorders, as will be fully defined subsequently by Dr. Naku, we used a tool that was able to measure what we call anxiety, GAD-7. Anxiety. Of the 100 people interviewed 18 years and above in the communities we visited, a third, 33%, for every 3, one of them had severe anxiety. What does that mean? Again, some of us may know, but Dr. Naku may expound on that subsequently. But also, we had another tool which measured depression. Again, for every 100 interviewed, about 18 had moderately severe or severe depression. Is it good? Again, to be expounded on, and those who are in this area know that this may not be good. Then we also assess alcohol use using the audit. For every 100, about 7 of them had harmful, hazardous, or alcohol dependency. Again, those figures may appear small, but they have a lot of consequences, as we shall certainly be helped to understand this better in context. So anxiety, again, was more common in females, depression, more common in females, alcohol use, more common in men. So we asked about the attitudes in the community. For every 10 persons that we engaged, 6 believed mental illness is caused by lack of self-discipline. 6 believed mental illness is like any other illness. 7 believed we are willing to continue friendship with a mentally ill person. 9 believed medication can be effective. And 8 believed they need to develop a more tolerant attitude towards the mentally ill. 4 in 10 believed that the mentally ill are a danger. So we looked also at the community level, the commonest mental health care and treatment pathway. When people have mental health, you know health begins at the house, in the home, where do they go? Some ride bicycles, others walk. For every 100, 80 of them, or for every 10, 8 said we first go to the hospital. It was a surprising finding, but again, we can discuss that. But also, about for every 100, about 9 said, well, we go to religious leaders for prayers. But also, other forms of care, for every 100, 5 of them say we first go to the traditional healers. And also we had a KI verbatim from one of the religious leaders who said, yes, they first go to the clinic, they go to the hospital in Botabika, they come back, but the state of life does not remain. It goes back again to what it was, and then they bring them here to church. So, integrating, now we know the patterns and burden as we are told. How does integration of mental health into the community happen? Integration is a tricky one, but we use some 4 domains. Do you have policies, guidelines, strategies, standard operating procedures in this community that you use for integration of mental health services? Or is there a human resource and human resource in terms of the training, development, but also the people who are trained to support mental health in these communities. We also asked about the communities' availability of supervision, support, and referral systems in the communities, but also issues of finance resources, commodities, and supplies in the communities to be able to manage and integrate mental health. So if we reported one of those, yes, then we said we had some degree of integration. What did we find out? I hope this can be seen. Of the 78 communities that we visited, 45 of them at the extreme end had some alternative forms of care, traditional leaders, religious leaders, but 33 had referral out. But even as they had those integration functional systems for referral, one of the most important things is that we see a variation. Jumani, with the 27 communities, 16 of them reported traditional, and about 20 of them reported referrals. So there's variation with the Kapchora reporting no referral in or out. So then the other thing we asked, does this community have a rehabilitation and integration of patients into the communities? So we had 78 communities, as I said, but 62 of the communities indicated that they are able to integrate and rehabilitate patients in their communities. And that also varied depending on where one was. I'll skip that. So some of the challenges encountered, or which we discussed with the community leads in there, they talked about long distances from their homes to the facilities, inadequate facilities in their communities, and drug stockouts, lack of enough health workers trained at the facility to support them, unawareness of members about mental health and availability of services. That was a big one. And stigma. Stigma was a big one that's associated with having mental health problems. And opportunities, yes. They already have parasocial workers in the communities, some of the communities, and I think they can tap into those to be able to enhance service provision. So my colleague will quickly walk through what did we find out when we went to the 2033 primary health care facilities and interviewed external patients who were exiting and had come for other services, not necessarily mental health. What did we find out? Rose, please.
Thank you, Prof. Good afternoon once again. Yeah, like Prof has said, I'm going to share findings from the primary health care. These results that I'm going to share were accrued from 160 patients who are exiting OPD services from the selected healthy facilities in our 4 studied districts. I'm also going to share results from the primary health care workers, including the facility in charges. So we did both the quality and the quantitative methodology. Like in the community section, majority of our respondents were coming from the rural areas. They were mainly female. Why female? I think it is very clear that men have poor health-seeking behavior, so this is not very new, except for these ones who are here. Dr. Onyero is laughing. Okay, we also, the occupation, by default, we are peasants. So we went ahead and assessed the patterns of common mental disorders. We used, I'm not going to call Dr. Naku because I've been studying mental health for some time. I'm not a professional, but I am going to try. So we assessed 3 common mental disorders. We assessed anxiety, depression, and alcohol use. So with anxiety, we assessed it using the generalized anxiety disorder tool, which is a 7-item tool. For depression, we use the patient's health questionnaire, which is a 9-item tool, and the audit for alcohol use. Ladies and gentlemen, of all the 160 patients that we assessed, none of them scored in the minimal anxiety range, meaning of all the 160, at least all of them reported some form of anxiety. And 3/4, that is 3 in 4, every 4, 3 of them scored in the severe anxiety range on the GH7. Why? Food for discussion here, but mainly maybe because people are struggling with the after COVID effects, land wrangles, domestic violence, name them, all those are contributing to the observed anxiety levels. Dr. Kalana, I don't know what's happening to the Zoom. Like in anxiety, even with the depression, wait. The Zoom is off. Okay. So with depression, just like in anxiety, none also scored in the minimal range. But we see almost 50%, almost 1 in 2 of the respondents scored moderately severe or severe range on the PAQ-9. That is also not good news to the specialists here. With the audit, that's where I get some good news. 74% scored, they are abstainers, they abstained from alcohol. Why? Maybe because majority of our respondents were female, or perhaps maybe they are not Catholics, because Catholics with alcohol. Aside from that, nonetheless, we also, on the audit, we have to close to 4% of the respondents who were scored as problem drinkers. 1.9 was adult alcohol consumption, and 1.9 still were scored as alcohol dependents. So we went ahead and assessed the causes of these observed results qualitatively. And the common causes that were mentioned were head injuries, mainly due to accidents that result in loss of proper cognitive functioning, drug abuse, which is common. It is really very common these days. Domestic violence, work-related stress. All of us here, if not none, have multiple engagements. You want to rush to this office, spend there some few hours, again you rush here, there are deadlines, there are these, there are deliverables. So all those ones cause work-related stress, which results in the common disorders that we have observed. Poverty. Yeah, poverty. That one I will not mention, but just know that majority of us are poor. And when you are poor, even the little that you have, the land that you have, you are also being evicted away. So you remain homeless, and you can imagine if you have a family and you are evicted from your land, you start imagining, where will I take the family? What am I going to feed them? All those ones could cause mental disorders. Relationship stress were reported by primary health care workers. That one is self-explanatory. So this was the cause of alcohol or drug abuse was affirmed by a health facility in charge, who said that addictions like too much alcohol, use of drugs like cannabis, currently as I speak, things like betting are the major cause of mental illness. We have heard on several occasions, even including the university students who have lost tuition due to betting, but also bigger men and women also engage in betting. So after losing bigger sums of money, one can even think of committing the other ugly one. Aside from the patterns, we also assess for the attitudes of the patients who are exiting care, about the attitudes, knowledge, and practice towards mental illness. So 5 in 10, that is a half, believed that the cause of mental illness was due to lack of self-discipline. That if you're not able to, if you lack self-discipline, you cannot determine how far you can go. That one, because they believed it causes mental illness. 3 out of 4 patients agreed that people with severe mental illness can actually fully recover. That is a positive one. 9 in 10 agreed that we need to adopt a far more tolerant attitude towards people with mental illness. Again, that is a plus. Medication can be an effective treatment for people with mental health problems. That is a good one as well. So now they will not be running to look for Jaja, Mutula, Congo, or the like. That's why these days Dr. Naku and the colleagues are complaining of Butabika getting full. I think people have started seeing the light, and this is a clear evidence. So nearly 6 in 10 said they would not want to live next door to someone who had been mentally ill. That is the stigma which Dr. Dokunyero was talking about. So as mental health practitioners, as the activists, I think we need to do some work to change these negative attitudes. Remember, our main objective was to assess the extent of integration of mental health services. So again, like in the community, we assessed extent of integration using those 4 domains. That is the policy, plans and laws, human resource development and training, supervision, support and referral, financial resources, commodities and supplies. So if the facility reported any of those 4, at least one of those would say that there is some kind of integration. So the first domain was on finance and commodity stock. We asked the in-charges whether they had a budget on which they were operating, and whether in that budget they have a mental health slot or a mental health vote. So out of the 32 facilities that we visited, 22 acknowledged that they had a budget, but without a mental health vote. So they budget for all other things, all other conditions, but mental health is missing. So 4 of the facilities had a budget, and within that budget, they also had a mental health vote. Sadly, 6 of the facilities neither had budget, general budget, nor did they have a budget for mental health. So they didn't have a budget at all. We went ahead and asked the in-charges how many of their staff were trained to offer mental health services. So we assessed the health workers who are able to identify any form of mental health problem, those who would do basic medication, those who are trained to provide psychosocial education or support, those who would provide crisis intervention, those who would be able to refer to a specialist. So out of the 32 now facilities that we visited, at least 30 of them had a cadre who would provide any of those services that outlined. So remember, we visited Kapchora, Adjumani, Bushenyi, and Butambala. And when you look closely at our results, Kapchora and Adjumani seem to be doing well. The 7 facilities that we visited in Kapchora, at least all of them had a trained personnel to provide all those services. Adjumani was working well on all the services. And Bushenyi was struggling, so is Butambala. For example, Bushenyi had only one health worker who would provide basic medical education out of the 9 facilities that we visited. And also Butambala had only one person who would do crisis intervention. So the PS here, I think she's taking note of that. We need to train our health workers to provide mental health services. So we went ahead and asked the in-charges, amongst their staff, how many were trained to deliver services by cadre. Majority of the health facilities named community health workers as VHTs, as a cadre that has been trained to offer mental health services. They were the majority. And the least were the medical doctors. I don't know. This is an area for discussion because at least I know the medical doctors rotate in psychiatry, so I don't know why they are not providing mental health services. And I leave it to the community health workers and the VHTs. We also assessed for the opportunities of integration because it was still low. And we said we could ride on the community outreaches that are conducted by the Host Center Force and the General Hospital. But currently, they do the outreaches for immunization, HIV, counseling and testing, and all other services, but mental health is not integrated. So they thought if we could include mental health services in the community outreaches that are conducted in the communities, then creates an avenue for integration. Thank you very much. I welcome Dr. Naku to take us through the findings from the schools.
Thank you, Rose. Our guest of honor, I'll go straight to the schools, but allow me, guest of honor, to recognize people from Ministry of Education because they were here after we introduced ourselves, to please stand up for recognition. If you're from Ministry of Education, we have 2 people sent by the PS here. Hope they haven't left. Okay. I'll go straight to the schools, what we found in the schools. We had 33 schools in all the 4 districts, schools that we went to, and we surveyed 1,366 children aged 11 to 17 years. We used the SDQ tool, the Strengths and Difficulties questionnaire for children, because it is specific for children, and it is specific for that age group. So we had children from both primary and secondary school. Among the children we surveyed, the majority were rural, as you would expect. These were rural districts. There was nothing Kampala about this. Most of them, half of them were female. That's not surprising. And as I said, the bulk were from primary schools. The other part were secondary school children. We used it is moving too fast. Why is it moving too fast? So we have surveyed the patterns of common mental disorders, and these are termed differently from the way we term the adults. We did not talk about anxiety or depression, but for children, we talked about emotional problems. This tool surveys difficulties, including some mental health difficulties. So among the children we surveyed, we found that 1 in 3 had high or very high scores on emotional problems. And emotional problems usually include anxiety, depression, and general mental health distress. We thought that was significant. Among those who scored high on emotional problems, the majority were female. Again, maybe that wouldn't be very surprising. The other issue they had, other than emotional problems, they had peer problems, difficulty relating in school. And those of you who are teachers and who have worked with children, this is significant and something we need to deal with. If a child is not able to relate with others, that child has significant problems. So 1 in 5, about 20%, had peer problems. When we looked at those children we identified to have problems, we found that they reported that these problems actually affected them in certain aspects of their life. 32.6% said these difficulties they have affected them in their home life. And 23.2% said that these problems affected them in their classroom learning. So if we want to have achievers in school, we're going to have to deal with mental health problems among learners. We did a qualitative assessment from other people who were not part of the survey to see whether there were any other mental health challenges reported in schools. And this is what we were told. Some people reported that some of the challenges, mental health challenges, this is the perception of the people we interviewed, that some of the challenges they have in schools is children who are being too active and stubborn, children who are depressed, children who have epilepsy, loss of concentration in class, loss of interest in studies, social isolation, and trauma. These are challenges people thought were dogging learners in schools from our qualitative interviews. And one respondent in our interviews reported that this is a school where you find people who talk to themselves while walking. Remember, we are talking about children. You find someone in class when he's seated, just there. But when his mind is not there, when he's somewhere else, this is quoting someone. He can strangely look at you. Even if you slap him, I hope they're not slapping the children, but this is what the respondent said. Even if you slap him, that person will not respond to you because his mind is somewhere else. He will be completely absent-minded. This is how someone was seeing mental health challenges in schools, in that particular school. We also explored mental health literacy among learners, among young people. And we used a tool called the Adolescent Mental Health Literacy Questionnaire. Again, our questionnaires for children were different because they relate differently to interviews. And in this questionnaire, this is what we found. We found that 63.5% of learners had erroneous beliefs around mental health. For example, some told us that mental health problems are for adults. Big people problems. Big people problems. That's what they believe. Some believed that people who get mentally ill are those who come from poor families. These are children. So there was a lot of, and more, there was a lot of erroneous beliefs about mental health in schools. Only 38% of these children had some knowledge about mental health, about the value of sleep and exercise. Probably they've been hearing a bit of it. So 38% had some knowledge. 32% had some knowledge about self-help, what you can do to help yourself when you feel distressed. And some 22.5% had first aid skills, knew about first aid skills. So we thought that there was very low level of literacy in the schools. And I think this is a very ripe ground to increase mental health if we teach it in schools. We looked at how, extent of integration of mental health in the schools. This is a slide to remind us of the domains we looked at. These were coined not by us, by the way, by WHO. Those factors that, help to measure integration, to try and integrate things into healthcare. We looked at human resource. Reported. In the 33 schools, we found that on average, 1 or 2 people are available to provide mental health. Most of the time, it was a school nurse. By the way, we were pleasantly surprised. We went back to this data to look and confirm that actually these rural schools have school nurses. Some do. It was very, very pleasant, a very pleasant surprise. So most of these are nurses. Some are senior women teachers and senior men teachers, but on average, 1 to 2. In some districts, one district, Bushenyi was doing so badly. The schools, none of them reported that they had anybody trained to provide mental health care or support for children in schools. 0. We looked at the domain of supervision, support, and referral. And in the districts, at least 13 of the schools, remember we had 33, at least 13 of the schools generally did some referral or had some kind of supportive supervision around mental health. When we put all the core domains together, I'll look at the next slide first. When we put all the core domains together, policy and guidelines, whether people heard or knew about, for example, the guideline on the 1 hour a day in school for mental health these days that Minister of Education is advocating, whether they knew about it or heard about it or had a document, whether they had some human resource, someone who has been trained to provide support, whether they did any referral or had support. When we put all those domains together, we found that of the 33 schools, 17 had none of those, 0. The other 16 showed that there was some aspect of integration. They had at least heard about a guideline or at least had a school nurse, at least one of the domains. So I'll go back to the previous slide. That is what it shows. The 16 had at least one of those domains, and that was the distribution. But most importantly, more than half had nothing, 0 whatsoever. They had some challenges. They thought that the lack of integration was because there's lack of knowledge about mental health among both the teachers and other personnel in schools, leave alone the children that we have already talked about. Even the teachers, by the way, they asked us a question. Dr. Naku, you are here to talk to children. Why don't you start with our teachers? we had that question in the schools. And I was hoping that Ministry of Education would be here. Unfortunately, they are not. But there's lack of knowledge among the teachers and other personnel within the schools. So if they don't have the knowledge, then they can't help the children. They also reported a lack of structures needed to handle mental health issues, which was due to resources. There's so much detail to these things we're summarizing. But they say these are young people, they're adolescents, they need privacy. So if a school doesn't even have space where you can sit them to talk to them, you take them to the staff room. The staff room has everybody. So they end up doing nothing because they don't have that space to help the children. There's a lack of motivation on the side of stakeholders. For example, the teachers reported that they do it on a voluntary basis. It's not part of their job description. It's not even paid. So they just help the children. And they thought that there's less attention, or rather little attention attached to mental health as an important issue to deal with in schools. That's their perception, that mental health does not have a lot of focus in schools. So there were also lots of opportunities. We don't have the slide here, but there were definitely some opportunities. They were telling us that since we have school nurses, why don't you come and teach these people to help the children? Also tell Ministry of Health to supervise the school nurses. Dr. Twine, that was a call from the districts. Because they said, but who supervises these nurses? Tell Ministry of Health to supervise these nurses so that they can help the children. So those were some of the opportunities. And also, Ministry of Health has a good system of senior women and men teachers who try to help the children, but they are not paid. That's a challenge. So in summary, and I'm summarizing for all my colleagues, all that we said, what we found generally in this study is that there's a high burden of severe anxiety, moderate and severe depression in the communities we studied. The burden is high. These are common mental disorders that may often not even end up in Butabika Hospital until they become so severe, until they become to commit suicide, for example, when they come. And yet, there are very many there. We could catch them there. There's a high burden also of emotional disorders and peer problems among learners in primary and secondary schools aged 11 to 17. Alcohol use disorder, the burden we found was similar, not different from what we have previously found in the communities. Up to about 10% is what we've been reporting. It wasn't different. But some of the limitations of this study are that most of the respondents were female because these are the ones who come to primary health care facilities, and these are the ones we find at home in the community. We went to homes. These are the ones we find at home. So we didn't have an opportunity to explore it deeply among the men. Maybe the picture would have been different. But that's what we found. It was as shocking to me as it was to Rose that 68.8% of the trained human resource for mental health were reported to be community health workers and VHTs. It is a good thing. But where are the formal health workers? Where are Dr. Diana Twine's people? It was a question that we had in the mind, but this is what was reported. We report the data as we got it. We also found that it is key to note that there is low literacy on mental health integration among learners, and mental health integration has significant gaps in schools. So we need to do something about schools. We found that there's a large gap in financial and trained human resource to enable integration of mental health services in the communities, in PHC and in schools. A financial and human resource gap. We need to look at that. Luckily, our guest of honor, it was gratifying to note that there's not zero integration. I was happy to find that. So, Dr. Twine, your ministry has been doing some work for sure. There is some level of integration of mental health in communities, in PHCs, and a little bit in schools, but the extent of this integration is little, and it varies widely between and within districts. You find some districts have a bit of this and others, don't. What surprised us was that a district like Adjumani with refugee populations, by the way, Adjumani was the best in this integration. And we thought that this was because it is supported a lot by implementing partners. And we had them here this morning. Everybody here came from Adjumani. Guest of honor, you missed the introductions. All the IPs came from Adjumani apparently. So mental health there is booming, and they were doing very well. They had an advantage for sure. So we recommended that we need an increase in investment in mental health by government of Uganda, also by international partners, so that we can achieve a higher level of integration of mental health in PHC facilities, in communities, and in schools. We also recommend that mental health should be mainstreamed in schools, in healthcare, and community programs, as is the case for gender, as is the case for HIV. Now we have also COVID, is mainstreamed. Mental health should also be mainstreamed to increase focus on it. Earlier on, one of the people who introduced themselves, Why Global, I was listening very intently. Why Global said they integrate all the activities and they have mental health mainstreamed through everything they do. Why Global? P.S. Why Global is also in Adjumani. Maybe we should work with Why Global now so that we learn how can districts mainstream mental health into their activities. I think that's a point for us to explore. We recommend also that we should establish a multi-sectoral working group at the national level and at the district level. National between the ministries, and at the district level between the various departments of health, education, and social welfare, and with development partners to improve coordination and improve efficiency. Leverage all the resources for mental health and work together. I think this multi-sectoral working group may be very useful. We need to harness the opportunities that are available, and there are very many opportunities mentioned in our study. We have not said everything, but there is an opportunity with Ministry of Gender. We called them, unfortunately they are not here today, but we worked a lot with them. Oh, they're here, Ministry of Gender, welcome. We worked a lot with Ministry of Gender also in the field. That we should harness the opportunity of Ministry of Gender having social workers in the communities. They're spread out in all communities, and they could actually enhance mental health at that level and improve integration. We would recommend that we design and implement periodic, continuous medical education programs for doctors, clinicians, and nurses, as well as for teachers. But this should be organized and run by the district health management so that it is local, more local, in order to strengthen recognition and management of common mental disorders at PHC facilities and schools. We suggest that we should explore, this was a missed opportunity, guest of honor. We need to explore further the burden of substance abuse. We talked about alcohol, but our questionnaires did not talk about other substances. In the qualitative inquiry, this came out everywhere we went as a big problem. We went to Kapchora and they said, we even have gangs like B13. It is a big problem, according to the community, that we were not able to explore. So we recommend that we should further explore, if anyone has money to do research, this is another area to go to, the burden of substance abuse in communities and in schools. It was also reported in schools. And design interventions to curb this problem that may be causing, triggering, or occurring as a result of mental ill health. I thank you.
Thank you very much. I think we have had a very rich presentation giving us the findings of the integration of mental health services into primary health care, community and schools in Uganda. And I wish to request you to give another round of applause to the team. Thank you very much. But what I noted, there is another form of addiction. We seem to be addicted to our phones. I don't know whether it is also a mental condition, but it's something that we need to deal with. At one interval, almost everyone was glued to their phones. So we need to overcome that addiction. But I know some of you be working, but let's limit the interaction with the gadgets. I wish to note that we are going to adjust through our program because time is not on our side. We shall not have the question and answer session, and we are going to dive into the closing part of this meeting. I'm told this is a half-day event, and we shall have Dr. Mutunji come, who will later invite our chief guest to make her remarks. We will have the launch of the report, which will involve signing of that signboard. And also we have some awards that will be given out. They are titled the MOH Partners in Mental Health and Rotary Club Recognition Awards, which our chief guest will handle after her speech. Allow me to take this opportunity to welcome Dr. Gerard Mutunji, who is the Assistant Commissioner in the Non-Communicable Diseases Department, who will also later invite our guest of honor. You're welcome and thank you.
Madam Guest of Honor, I had already given my remarks. I think this is just an opportunity to welcome you to come and address this audience. But before that, I will give you a synopsis of who is here. But also before that, I'm going to request all of us to stand up because we've been seated for so long. And this may cause some mental health issues. So you stretch, depending on the space you have. I don't know whether Karani, you want to give us some energizer. Can we run stationary? You run. Do some running. Do some running. The Basoga have a name that they call it. Do some running. So that we are not exposed to mental health. We've been seated. Okay, we can sit. And promise me that when the guest of honor is speaking, we shall limit the phone use. Are you promising me that? Yes, Madam Guest of Honor, you see the energy in this house. We have so many partners here, and the energies they showed me, it looks like the 14 million will reduce to 4 million in the near future, isn't it? Yes, and most of you are in communities. That's what I liked. Because mental health should not be in Butabika. Mental health should be in the communities. And most of you are from communities. Guest of honor, I want to mention a few of the partners that are here. And if I mention your institution, you stand up so that the guest of honor knows that you are in the house. We have government agencies. We have Ministry of Gender. Can you stand up for recognition? We have Uganda Police. Can you stand up for recognition? Guest of honor, we have the Mungerera family. You know how passionate the late Margaret Mungerera was. Guest of honor, we have the Indianabanji family represented here. I think the dear husband, the late Indianabanji, is here. Thank you very much. We have the Butabika National Hospital. Please stand up for recognition. The guest of honor should know which people is addressing. We have, of course, Makere School of Public Health. That one has a name. If I wanted to mention it, it will cause me health issues, but I know it's Raymond. The other one will cause me some mental health issues. He's there. We have TPO Uganda. Please stand up for recognition. TPO, the guest of honor, wants to know that you are here. JRS, Global Health Corps. Y Global, Repsi, yeah. You Belong, Basic Needs Uganda, Fine Minds, Abba Behavioral Health Services, Kafomi, Israel Aid. Israel Aid, I'm told you are going to Nachivari. It is in my neighborhood, so you better see me, I give you the directions. Thrive Uganda, Thrive Guru, Thrive Guru. Strong Minds Uganda. Guest of honor, we have also Rotary Club. Thank you very much. War Child Holland, 30 Uganda, Tutapona Uganda, Safe Places Uganda, African Retreat Center, Uganda Counseling Association, Refugee Law Project, Uganda Association of Psychiatrists, and the guest of honor, we also have members of parliament. Some of them have greeted this function. We are grateful for your attendance. So because of time, Madam Guest of honor, allow me invite you to come and address the audience. Thank you very much.
Good afternoon, ladies and gentlemen. I want to begin with recognizing the protocol, Honorable Member of Parliament, our senior officials from the Ministry of Health, Professor Roda from Public Health, School of Public Health, and your colleagues. I want to also recognize all partners, the implementing partners that are here. And I don't know whether we have World Health Organization and World Bank teams. Are they here? Do we have them here? Okay. But I want to also acknowledge the presence of other ministries like gender, police, and other agencies. I welcome you. I really don't want to stand between you and lunch. I think you've had a very busy morning and you have had information overload. I want to welcome you all on this important day as we celebrate the World Mental Health Day 2023. The day is celebrated globally on 10th October, but the national celebrations were pushed to today. So that's why we are here today. And the theme
of this year, mental health is a universal human right. And I like when they said, my mental health, my right. It is so right at this time, especially when we are seeing that the non-communicable diseases, including the mental health disorders, increasing exponentially, and it is estimated that by 2030, the mental disorders among the 10 non-communicable diseases will be actually the most prominent diseases that will be affecting the human race. And so coming together today to discuss and to review the progress we have made, but also using research findings to help us to commit the next step of action is so right. So the theme for this year is mental health, is universal health, human right. And as a country, our tagline is my mental health, my right. It provides an opportunity to draw attention to the growing burden of mental health conditions and therefore need to focus on their holistic management so that everyone enjoys their full potential without the disruption of mental illness. The day also calls for committing to acknowledging or to acknowledge the importance of mental health, to be more open and accepting about it, and to prioritize availability of funds and access to care, treatment, rehabilitation of persons with mental illness. The COVID pandemic made it so evident that there is no health without mental health. And I'm glad today it came out clearly in our presentation, and even when the keynote address speaker touched on it. WHO Mental Health Report in 2022 showed that there was a 25% increase in depression and anxiety during the last 3 years of the pandemic. And I think the results that we have seen here today testify to that the mental health issues are on the rise. And we do not know how it will be in the next 10 years if we continue at this trajectory. I don't know what will happen. And so this calls for all of us, not just health, not just a few people in the mental health field, but all of us. And as you have seen, children and adolescents were most impacted even at the time of COVID, but that effect seems to be continuously growing, especially in schools. And I think this is because children have no idea, even when they get this mental illness. By the way, it's not only children, but even adults. Our community does not understand the magnitude and the dangers of not dealing with the mental health at earliest stage. People tend to panic to go into managing the mental health when it is life-threatening. Always we tend to come in when it is right at the threatening, life-threatening. We forget that disease prevention starts at early detection. And early detection is what is right now missing in our communities, especially the rural. As government, we are mindful of the fact that people with mental illnesses may not be able to access effective and relevant support as well as appropriate treatment due to many barriers within their communities and within our healthcare system. We are also aware that mental illnesses can be triggered by circumstances from family, workplace, education institutions, and different forms of conflict. And I think clearly we have seen it in the presentation here. The stigma, as was discussed earlier, the stigma and discrimination experienced by people with mental illnesses not only affect that person's physically and psychologically, but also affects their educational opportunities. And I think those of you who have been in this field, you know that we have seen so many young people drop out of school, but in a manner that people take it lightly. It's just behavior. Someone take it, it's just behavior. This person is difficult, is just a difficult child. And they fail actually to detect that it is the illness, it can be dealt with, it can be treated, and this person can go back and study. And many of our young people have dropped out of schools because the mental illness they have had, even in a subtle way, has not been addressed. And that has an implication of our future generation. Our future generation depends so much on these young people at this time. These are the future leaders, these are the policy makers, these are decision makers, these are opinion leaders in the community. And so it is so important that when we are discussing these things, we reflect, first of all, to begin with where we come from. How have we been of help? To help even parents who don't know what to do. Because of the stigma, even parents don't want to come out and seek help and take their children to counselors so that we begin from there. Because at the counselor level, someone can detect that there is a problem. But also counselor level can prevent further the deterioration of that mental illness into adverse illness. Even there is a saying that the problem shared is the problem halved. Many of those people who are depressed, who are anxious, we have seen a high level of anxiety among children. But you find that even the teachers, parents at home have no knowledge whatsoever. But if these children are counseled, for example, we have social workers in schools to detect some of those. Sometimes children are taken as they are difficult. Then they are chased away from school. And then that exacerbates further the problem, the anxiety even or depression. And then it gets into severe form to even a level of committing suicide. I've heard these days even young people are committing more suicide. Why? Because the issue is not dealt with. They are not able to share their issues. And because of that, it piles up. What I am shocked about these results is that women in this study are more affected. Maybe it's because also they were more. The sample was also looking at mom, but also maybe at that stage, because young girls at that stage, they are traumatized. They go through a lot. That teenagers, we are talking about teenage pregnancy. These are young children who are being bombarded by society with advances from men. So I think that is, but if we stratified these ages and we looked at older people, men are worst hit. Men are worst hit. Actually, the older men get, the worse it gets, because they think they are men. They are men. They are managing. They have to die as men. They cannot open up. They cannot go for counseling. They are men. They know how to deal with their issues. And then they bottom up. But you realize that the older women, beyond this adolescent group, for us we talk, we are like goats. We scream. Anything happening, we scream. While in the screaming, you let out the steam. As you are screaming, you are letting out the steam. So that helps. And you find actually in older women, we do not have much depression. Because, and I think, I don't know, but for me I'm speaking from what I know. And statistics must be there really to tell. Because men, even now go to our mental hospital. You'll find quite a number of them, especially when it gets to these addictive disorders. Because they want to find solace in doing certain things. They decide to become sex maniac, they go into that. They decide in alcohol, they go into that. So we know that men at older age, that the statistics could be different. They are different from what we see, because here I think it was mainly the school. But we need to come up with solutions that will be able to address all those issues at every stage. And we cannot have the solution for that whole a cross-section of age groups, because the approach definitely is different. These inequalities need to be addressed and not be allowed to continue. We all have a role to play to address the stigma and ensure that persons living with mental illness are fully integrated in all aspects of life, as it is their right. Furthermore, we need to locally generated data that will inform our interventions to improve mental health services. The government of Uganda has made steps towards improving the treatment and care of people with mental, neurologic, and substance use disorders through the following. Dr. Naku here had told you that we were also working. We are working, we are not sleeping. Number one, we have created partnership at the different levels of care to ensure that there is continuity of essential health care services despite the disruption in the referral processes. When I walked in here, I was very excited because I knew that mental health is one area that really does not attract. It does not attract attention in issues of partnership. But I was very excited when I came here. I saw so many banners, I was like, what? All these are in this field? I was very, very excited. So I really want to thank you and I want to congratulate you to choose to support this important aspect of health care. But I heard also the wind blew nearly everyone into refugee hosting community because that's where funding is. But we want to see how we can spread ourselves across the country. Because also non-refugees Ugandans need these services. We need these services. So at Jumani, you have done great, but can you move to Kapchora? You saw the statistics. Can we move to other districts? So number 2, we have developed and disseminated legislation which is supportive of the rights of people with mental health problems. But it is also different if you have the legal framework, but when it is not well understood by the users, but also by the population, by the community. It just remains something on the shelf. So the work that we have is to make sure that these documents that have been developed are well articulated in our population so that they know exactly what to do when they encounter something like that. Number 3, we have improved the range and quantity of medicines for the different mental disorders in the country. Although this is still not sufficient, because as you see, more numbers are coming. The population is increasing, as well as mental disorders. That means the funding must be in consonant with the numbers that are increasing. Otherwise, even when the funding has been increased, we see still, especially in our lower facilities, in regional referral hospitals, in general hospitals, these medicines are not easily accessible. We have also built capacity of the healthcare workforce at different levels as far as treatment and care of mental illness patients. However, I think we have not reached, we have not saturated. And I am glad that it is coming out here in our recommendation that we need to increase the training. And one of my major focus on, as I'll talk later of my speech, is the issue of integration of services. And I am so glad that also the previous speakers kept on talking about it. Integration, 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 integration. When I come with TB, the tendency is that the physician who is going to see me to treat me, they will just look for symptoms of TB and prescribe medicines for TB, and I walk away. But if this physician who sees me, or also in the process of checking me, interacting with me, looks at my demeanor, looks at my body language, and is able to pick already that component of mental health. Because even other diseases can come and then mental health becomes secondary. When people have got chronic illness, let me tell you, diabetics. I would be in diabetic clinic, and half of my time I would be counseling people why they need to continue taking their medicines properly, why they need to take care of their feet because they would get paresthesias, why they need to continuously checking, coming back for check, because someone would just say, I am fed up. I'm just fed up. I'm fed up of injecting myself. I'm fed up with this. Now even my feet are not, now my sight is poor. I'm just fed up. Especially when you give them the knowledge that, you know what you have now here, it might be it may not be reversible. Or the paresthesias in your feet or diabetic foot, I will only treat and make sure that I teach you how to take care of your foot, but it will not change. That alone creates the other mental illness now. So if we do not integrate the services so that when we are looking at these people, we look at them holistically. Holistically. So that when you are treating a patient, and really our medical people need to know this, the nurses need to know this, the community workers need to know this, even the VHTs need to know this, because they are the people who interact on a daily basis with these people. So that integration, we cannot overemphasize. It is so relevant, it is so needed, it is a game changer. I therefore call upon all leaders at different levels, the different MDAs, and the general public to join our call to action in ensuring that mental health is prioritized and integrated in communities. I expected to see prison services here. Did we invite them? Prisons. These are people who need our services. These are people who are dealing with people who are just like, life has become automatically, they become prisoners. Automatically, they get mental disease. And these are people that need to build capacity. I am glad to see the police representative here. But the army, security personnel, we need them here. We need the people who interact with them, the social workers in these groups. Because somehow we tend to forget them. They are part of us. They are our sisters, they are our brothers. Yet the work they do, put them at the front line of the mental illness, interface directly in their face. So we need really to look at special groups. The young people here, if you go to, I had an opportunity to visit the Masulita, where sometimes they pick all these children in town and take them there. So I had given myself the task that I'll be creating time, and I go and sit with those children and just talk to them and treat, would get medicines and go and do medical camp there. But every time I would be interacting with those children, you just feel your heart breaking. Because they would just tell you stories why they ran away from home. And you see this is a whole generation. And these are orphans that belonged to some parent who delivered them at one time. These are children, these are created in God's image. And somehow they are just there. And they have issues. And nobody is there to listen and alleviate the weakness. And they go for those things they sniff. Those, I don't know, fuel or something. Yes, and they sniff. And you talk to them and you just feel. So these are things that we must address, because we were not going to wait for other people to do this for us. Integrate at all levels. Gender, I don't know how much time we take time to listen, to sit with these children and come there. in the districts and in these institutions. But this is a lot of work that that whole generation has a ripple effect. So I care workers to get mental health awareness and do things that support their own mental health and that of colleagues. We need to in order to help others through recognizing diversity, promoting equity, and adopting behaviors that inclusive working environment. Again, from the study, you note that school institutions should identify factors within the environment that can undermine and explore resources to improve and promote our social environment. How many medical workers do we have here? I know that we have our circle. How many, just by show of hands? We need to create a wellness program. You cannot give what you don't have. You cannot counsel someone. You cannot make someone feel good. You cannot lay anxiety of someone. You cannot even recognize that someone has a mental. When yourself, you need to first be sorted. And this is some the medical association, but I don't know how far we have gone. But this is something that is so important. The care of the carers. Very important as I conclude this. First, to recap what I wanted just to emphasize. Number one, we must train our health workers and to recognize all forms of mental illness. Number two, we need to institute programs in schools to create an environment where young children have less stress. I was telling Rhoda, my daughter, she was telling me, wakes up at 4 to go to sleep because they are now in exams. It is so stressful. The girl is so stressed, you can't believe it. Some of the sources of stress for our children. So we need really to find a way, and I feel bad that education. I pray that we'll advocate for better environment for children that lessen the stress. We need to continue to sensitize our public, the community, that the mental health, but it can be prevented and it can be cured. Because we are losing many when we would not have. We are still believing in a... Even people who are educated apparently, they think Mayembe, Chifalu, what, Nyabi. People talk about, and they miss the care. And by the time they come to get treatment, and you lose a person. So that continuous sensitization is so important. Lastly, so on our side to commit that within our means we shall endeavor to increase awareness of our people in our facilities and make mental health not only stop at the national referral and even general hospital, because people don't have money to travel the way. You imagine someone in Amdat going to Moroto mental health. That's how they remain in the community, and they never get treated. So we need to see how we can expand even lower facilities. I want to take this opportunity to thank the partners, the support study. I want to thank the and most importantly, I want to thank the partners, the implementing partners that have been in the community, that have supported us. For God and my
Thank you very much. We could appreciate more. It's at request that we have the official launch, signing of this guest of honor, together with also direct into referral hospital and self sign on the placard. Government, Ministry of Labor, Gender.
Us once again, that is how we are winding it up and commemorating the World Mental Health Day, which has been at Silver Springs, Bugolobi, and that's how it's been. After the speech of the Permanent Secretary, that is Dr. Diana Twine, we are just crowning it, and that is it. She said, let it be your work, my responsibility. But lastly, I like what when she called upon many players from the army, say the policemen in uniform, come on, join the chariot, other stakeholders, come on, let's engage in and be together and pose a great threat to this mental challenge, which is everyone. We are the theme, we've been running with a theme that mental health, my right, or my human right, which has been celebrated on the 31st of October 2023. My name is Chintu Mutesasira Senior. Thanks for joining us. Thanks for being with us. Until we meet again, it will be tomorrow. Good afternoon.
Bethany TV for Health. Introducing Bethany TV, the pioneer health and wellness channel in Uganda